Yeah, so Dr. Morse is an associate professor in our division of general internal medicine. She obtained her undergraduate degree at Boston University. She then moved on to the University of Washington, where she first obtained her master's in speech language pathology, then her PhD in rehabilitation science, and finally an MPH in health services with a focus on health policy. She completed two postdoctoral fellowships, the first at Northwestern and the second at the Mayo Clinic in Rochester. And we were fortunate to be able to recruit Dr. Morris here to the University of Colorado in 2016. The aim of her research is to improve the quality of health and healthcare services received by persons with disability. She leads a multi-site national study which uses a stepped wedge study design to compare education versus education plus a patient-directed tool to help improve the quality of communication between patients with communication disability and their healthcare providers. Dr. Morris will be sharing her expertise with us today with a talk entitled Incentivizing, Enforcing, and Improving Equitable Healthcare for Patients with Disabilities. Dr. Morris?
Great. Thank you for that introduction. Thank you for taking the time and attending the session today. So I will be sharing information, some data from a qualitative study we did as a part of a PCORI, which stands for the Patient-Centered Outcomes Research Institute grant that we received. So I need to acknowledge the grant and add my disclaimer that this is solely the responsibility of myself and my co-authors. So just to start off, persons with disabilities comprise about 25% of the U.S. population. So they're actually quite a significant proportion of those in our country. And this, we're taking a fairly broad definition of disability, and it covers individuals with mobility disabilities, hearing disabilities, vision, communication, cognitive, and mental health disabilities. And I won't go into it today because we could spend the rest of the day talking about the literature, but a growing number of studies demonstrate that individuals with disabilities experience significant disparities in the receipt of high-quality healthcare services. So to give a few examples, first we have here is multiple studies have demonstrated that individuals with disabilities have lower rates of cancer screenings and other preventative care receipt. And so, for example, I'll give an example of a cancer screening. So women with mobility disabilities, so maybe a wheelchair user, they have difficulty getting transferred onto a exam table to have a proper pelvic exam. And so again, we see much lower rates of pelvic exams, also mammography in women with mobility and actually cognitive disabilities as well. We also have data that individuals with communication disabilities and mental health disabilities have much higher likelihood of receiving or experience a preventable medical error when they're in the healthcare setting. So in recognition of these disparities, we actually have multiple laws that require the provision of equitable healthcare to individuals with disabilities. So we first have in 1974 the Rehab Act, specifically Section 504. More recently, in 1990, we have the Americans with Disabilities Act. And this is really key. The Americans with Disabilities Act was our first large-scale non-discrimination law for, again, non-discrimination against people with disabilities. And part of the Americans with Disabilities, or the ADA, it does mandate the provision of accessible care. So again, I'll draw your attention to the date of 1990. This is over 30 years ago. This was, again, mandated. And then more recently, we have the Affordable Care Act. And specifically, there's multiple sections, but I'll draw your attention to Section 1557, which prohibits healthcare organizations from discriminating against patients based off of race, their color, national origin, sex, age, and then it also included disability status. So again, despite these laws being in place, we continue to see disparities in care. And so, so the aim of our study was to understand sort of the effects of these laws. So again, we have these laws prohibiting discrimination, but also requiring the provision of accommodations in the healthcare setting. So we sought to understand multiple stakeholders' perspectives on the effectiveness of current laws and policies, and then understand their perspectives of how to increase equitable healthcare for people with disabilities. So we started the study in May 2019, got a little pause during the beginning of the pandemic and finished up in January of 2021. We conducted key informant interviews with 55 stakeholders. And so you can see here our distribution of the stakeholders we talked to. So we talked to a number of healthcare systems, researchers, advocates from a wide range of types of disability. We talked to policymakers and payers. So this was private and public insurers, accreditation organizations. We talked to CMS, etc. And then we also talked with representatives from several professional organizations. So we conducted these interviews. They were about an hour long. We had them transcribed, and then we conducted a content analysis, which is a qualitative content analysis on those transcripts to identify the major themes. So I'm going to now move into talking about what those major themes were. Okay. So the first theme was existing laws are necessary but not sufficient. So across all of the participants, they reported a gap in the enforcement of these laws. Specifically, there's really, they talked about there's really no ADA police going around and making sure organizations are accessible, again, providing required healthcare accommodations and providing equitable care to people with disabilities. So the teeth behind the ADA is individual patients filing lawsuits, and then also filing complaints with the Department of Justice. Multiple participants reported that this was specifically organizations from individuals who represented healthcare organizations did say that that these lawsuits and complaints were effective in promoting change. Unfortunately, they reported that this change often tapered off over time, the longer from when, again, the complaint was filed. And also very problematic is that these lawsuits are intermittent and rare. So it takes a lot of energy and effort of patients to file a lawsuit, and so many don't do that. They either suffer through the care they're provided or switch healthcare provider. So you can see here this is a quote from a participant. You might respond too late, in a sense, to serve the patient who's suing you, and maybe you change your practice for the next patient, but maybe you don't. Maybe you just take the hit and then you move on because it's not really that worth it to make a lot of change. That's the problem with lawsuits. They're intermittent. It's kind of intermittent incentive. Participants also stated that these laws encourage health systems to do the minimum required. So they saw that what was required by the law as a ceiling rather than a basement. And the other challenge with laws is, and the penalties with the laws, is that organizations might be reluctant to seek out assistance. So perhaps they are, they recognize that maybe they are not providing equitable care, or they're not providing healthcare accommodations that they're required to provide, such as height adjustable exam tables, or weight or wheelchair accessible weight scales, or sign language interpretation, those types of accommodations. So if they're not providing them, they might be worried about reaching out and really exposing themselves to potential lawsuits. So in response to how do we address these concerns, there was a strong belief of tying funding and reimbursement as well as accreditation to accessibility. So as this participant reported, I actually could see that there are policy levers that would encourage implementation, whether it was that we took this more seriously, that we said, okay, you won't receive another Medicare payment until this is changed. People would change their behavior overnight. They would adhere to the law. In addition to, again, reimbursement, they thought, multiple participants thought of tying accreditation, such as Joint Commission accreditation, to, again, being accessible and providing equitable health care. And so this would require the involvement of multiple federal agencies and our accreditation bodies. Our second theme is to recognize that disability is an equity issue. One of the huge gaps that the participants reported was the gaps in leadership knowledge, so healthcare organization leadership and providers, and their knowledge about what is required under, again, the ADA and also the ACA. There's also a huge gap in how to, again, provide equitable care, what accommodations to provide, and how often to provide those accommodations. There are many misconceptions about what the requirements are, and there's also a belief that persons with disabilities are a small population. And so participants talked about interacting with leadership, and leadership saying, well, this is a lot of effort. This is a lot of money for, only, a handful of patients. But again, it goes back to what I talked about at the very beginning. A quarter of our U.S. population has a disability. So it is a very significant number of patients who require and would benefit from healthcare accommodations. There are also many biases and assumptions about persons with disabilities, and these biases and assumptions really color the motivation and the priority of healthcare organizations in, again, addressing and creating interventions to improve the quality care to these patients. And as we all know, healthcare systems and clinics, they have many priorities and many competing priorities, especially over the last several years. And so providing accommodations, especially if they are not they're unsure of what they're supposed to be doing, this often then falls low on the priority list. So to address these concerns, participants reported that one solution was to integrate accessibility or disability accessibility into diversity, equity, and inclusion efforts. So oftentimes DEI efforts really focus on race and ethnicity and maybe include the LGBTQ population, but more rare that they include individuals with disabilities. And so if organizations and clinics are already, have committees put together and have efforts and initiatives going on about diversity, equity, inclusion, work to integrate disability in those efforts and take a more broad perspective of what diversity looks like. Participants thought that, again, it goes back to the lawsuit. So I'll read this quote here. It's not that there's nobody that's driven by lawsuits, but there are a lot of people that are driven by more noble reasons. I think we capitalize on that. Another participant talked about, reminding providers of why they entered into medicine and aligning providing equitable care to patients with disabilities with that mission. And they did, many of the participants reported, describe a lot of the gaps in current practice, but there was also this belief that providers and leadership really want to do the right thing. And so it's, we need to come around them and help support them and provide them the education and awareness of the challenges. And again, what is required for providing equitable healthcare to people with disabilities. The third theme I will discuss today is healthcare is driven by cost, quality, and competition. So cost. There is a cost to providing healthcare accommodations for people with disabilities. So for example, we'll talk about a height adjustable exam table. This is the table that can be lowered to what is recommended to between a 12 to 18 inches, depending on who you talk to, what that low limit should be. And that it makes it easier for an individual who is a wheelchair user to then be able to transfer over and to that exam table and have a proper examination, physical examination. Those tables are more expensive than our standard not height adjustable exam tables. And so there is a cost associated with providing these accommodations. Additionally, there's a cost to retrofitting our buildings. If clinics and hospitals have older buildings that were designed prior to the Americans with Disabilities Act, they might not have ramps or elevators or properly fitted bathrooms with grab bars and push buttons. And so all of that does require cost. And so historically, those costs have fallen to the healthcare organization. And so, for smaller practices like a primary care practice, like a solo practice, that falls on, onto those costs fall onto that practice. So participants recommended that we take maybe a more broad perspective on who contributes to the cost of covering these accommodations. Participants thought that perhaps state and federal payers can assist with this. And we will say that some states do have actually grant programs for practices to apply to receive funding for these accommodations and retrofitting. And there's also some tax breaks already in place for, again, purchasing these equipment. But also individuals talked about private payers. One payer is Centene. We don't really have it here in Colorado, but they cover other states, and they are a managed care organization, and they actually have a barrier removal fund that practices can apply and receive grants to, again, purchase equipment to make the physical modifications. And then also, again, health system clinics and providers are a part of, again, covering this cost. Universally, people said patients should not be contributing to this, and this actually is consistent with the law. It is not the responsibility of the patient, and it's illegal to actually ask the patient to pay for their own accommodation. Quality. So I'm going to read this quote here. Outcome benefits, efficiency benefits, cost benefits. To really know that resources and effort put it in on the front end have a benefit on the outcome in the sense that we are generally looking for. Readmission rates, reduction in ER visits, the things that we typically look at that can improve patient experience and patient satisfaction scores. If we had research that actually showed that, you would see every healthcare organization in the country doing it. So universally, we again also heard from our diverse stakeholders that we needed more evidence. We needed evidence that providing these accommodations not only improved care and improved care outcomes, that they also prevented errors and staff injuries and so safety outcomes as well. Unfortunately, we just were a really new and growing area with not a whole lot of researchers in this area, and we a lot of the efforts thus far have been put into really describing the disparities. And so we as researchers, it's our job, I believe, is to take the research to the next level and to start looking at how does providing accessible, equitable care accommodations actually improve our outcomes, because that is going to be a huge motivator for our health systems and providers. And then lastly, competition. Participants recommend developing directories of clinics or hospitals who are accessible. And actually the CMS is currently conducting a pilot study of doing this. This is, again, self-reported. So providers go in and report what type of accommodations that they have available at their clinic or at their hospital. No one has gone through and actually looked to make sure that if someone is reporting accessibility, that that's actually truly represented in the actual clinic. There's also an interest of creating a grading or a magnet status or centers of excellence to really encourage competition amongst providers, clinics, and hospitals. So you can see that here in this quote of, it's important for our patients and it's important for our reputation. It's important because it's the law. If individual physicians or individual leaders or individual people within the organizations advocate for it, you definitely can make change. I think there is an opportunity here. So I'm going to move on to conclusions. So you can see here, I put here are the major challenges that participants reported, and these are the potential solutions offered. So, solutions tying reimbursement and accreditation to accessibility, which requires some policy changes, cost sharing amongst payers, healthcare systems, and providers, integrate disability accessibly into DEI efforts, increase research to demonstrate improved quality, and then also build competition. So I will not take too much time because we're near the end of our time today, but want to talk about one way we are working on moving things forward. From our key informant stakeholder interviews, we had really great response from the people we talked to. And actually what we ended up doing after we did these interviews is host a meeting, and we had 80 people show up. So again, we had individuals who represented private insurance companies, multiple groups within CMS, a joint commission, the hospital association, and then advocates and researchers and health systems. We got together and we said, okay, how can we work together to move things forward and advance equitable healthcare for people with disabilities? And so from this, we've developed what we call the Disability Equity Collaborative. And this is, again, a collaborative of individuals working together. And we have multiple work groups. So we have our practice work group, which currently we have about 50 health systems from across the country who meet every other week to encourage each other, help support each other, get advice from each other on how to implement healthcare accommodations and accessible care for people with disabilities. So really boots on the ground. And in that group, we also bring in researchers presenting evidence. We bring in policymakers and advocacy organizations to really, again, have this collaboration between people who are implementing things and those who are studying or are making recommendations. We have a research work group that, again, we're working to encourage other researchers and build up junior investigators in this area. We have a work group focused on documenting disability status in the electronic health record, because this is, for us to move both practice and research forward, we need better data. And so we are working on creating requirements for EMRs for how to document disability status. EPIC is involved, sort of Verona, Epic in Wisconsin involved, and we most recently presented to the Office of the National Coordinator for Health Information Technology about this need, and actually they just in the last few weeks passed requirements for all EHRs to ultimately require them to have a place to document disability status in the EMR. So again, this is, I think, a piece of advocacy that the Disability Equity Collaborative has been able to work together on. And then finally, we are working on putting together some guidelines and implementation guides for implementing accessible healthcare for individuals with disabilities. And I will acknowledge the Corey Eberly and Steve Lockhart, who were instrumental in conducting these interviews and analyzing and moving things forward with me. So thank you.
Great, thank you, Megan. While we await any questions in the chat or Q&A, I'll maybe start us off. You know, as you so eloquently highlighted, the persons with disabilities is a large proportion of our population, yet it's a very heterogeneous population. And how do we, you know, sort of prioritize what accommodations, you know, make the most sense, you know, given the reach that that accommodation might have, as well as the cost? Like, how do we, you know, how do we prioritize? We can't do everything all at once. And what's sort of the, and is that fact that it's so heterogeneous part of what has prevented any real movement in that direction?
Yes, that's a great point. And I would say that it has in some ways, because maybe you'll focus on accommodations for one, you know, subpopulation. And again, people, the, you know, health system is like, but that's such a small population, you know, we don't have the time and effort to really focus on, you know, just again, a handful of patients. I would say that when we've talked to patients and about with, again, diverse disabilities, you know, how can the healthcare system be more accommodating to you? And they said, yes, there's the physical accommodations, but the biggest thing they asked for is flexibility, is that the healthcare team works with them, that they say, how can we help you participate in your visit today? So, you know, there's a lot of very, you know, no cost options. So for example, someone with visual disability, they, you know, walking into their exam room, and flipping on the lights. Well, the lights might be difficult for them. And so turning off the lights is, again, a very way to provide accommodations. We have people talk about they had difficulty filling out the medical forms, or you know, the intake forms in the waiting room, and the clinic saying, we refuse to see you unless you sit in this waiting room and complete this form. But if there was someone who actually read the form to them and they answered, and then that person read, like wrote in the answers, again, doesn't take a whole lot of cost. It does take time, but that is an accommodation for some visual disability, a cognitive disability, other communication disabilities, motor disabilities. So there are these, again, accommodations that the healthcare team can do that actually cross multiple types of disabilities.
Great, thanks. All right. I don't see any other questions in the chat or Q&A, and we are at 1 o'clock. So I think with that, we will conclude today's Research and Innovations conference. I'd like to thank Dr. Morris and Dr. Baer for excellent talks, and for those of you who attended and participated in today's conference. We'll see you next week.